to the other camera, just so you know, so I'll be off and on.
Thank you.
All right, and we're live.
Okay, wonderful. So good afternoon. Welcome to the Health and Government Operations Committee. Please do not forward the Zoom link for the hearing. Staff will not allow anyone who was not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witnesses timing. This is really important. The bill sponsor or designee is allowed 5 minutes to present the bill. 5 witnesses will each be allowed to speak for the 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. So the panels will go first and then we ask the question. If there is some time left from the primary sponsor, that time can be given to someone else. The next 5 witnesses, I said, will each be allowed to speak for 2 minutes in opposition and then respond to the questions. Please conclude your remarks when you hear the timer ring, very important. Members must remain present with your video camera on during the entirety of the hearing. That is the rule from leadership. Members, please ask only 1 question of 1 witness. If you have other questions, you may follow up offline. Please use the raise hand function right under the participant icon to indicate that you have a question. The bill hearing order today, we're going to start with House Bill 209, Delegate Bill Castro, followed by House Bill 318, Delegate Young, followed by House Bill 28, 309, and 78, which are Delegate Peña-Melnick, myself. We will break at 3:15 if we're not done, and we will reconvene at 3:45, only if we're not done. Thank you so much for being with us today. So let's start with House Bill 209, Delegate Bill Castro, Public Health, Maryland Suicide Fatality Review Committee. Good afternoon.
Good afternoon. Thank you, Vice Chairman Peña-Melnick, and thank you to the members of the Health and Government Operations Committee. I can't think of a better place to be for my first bill hearing than right here with each of you. For the record, I am Lisa Bell Castro, and I'm testifying on House Bill 209, Public Health, Maryland Suicide Fatality Review Committee. It's widely known that there's a mental health and suicide crisis in our state. House Bill 209 is a response to these crises, which have been exacerbated by the COVID-19 pandemic. In 2009, the Governor's Commission on Suicide Prevention was established. The commission's preamble identifies suicide as the 11th leading cause of death in Maryland. House Bill 209 is an extension of the commission's efforts to prevent suicide deaths. This bill establishes the Suicide Fatality Review Committee to examine factors contributing to suicide deaths. The committee will study trends, risk factors, best practices, lapses in response, and barriers to safety. The team must meet quarterly, make recommendations on policy or law changes to both the governor and the General Assembly. And studies and findings will be disseminated to policymakers, healthcare providers, healthcare facilities, and the public. And for a little bit of context, a similar committee was created in Oregon, and through this similar process, they found a high number of people drop their dogs off at shelters prior to committing suicide. So after identifying this trend, the state began training staff members at animal shelters, which created another opportunity for intervention. Creating preventative interventions to the suicide crisis will require necessary data and information. House Bill 209 seeks to provide just that. I appreciate your consideration, and I respectfully ask for a favorable report on House Bill 209. Thank you very much.
Thank you, Delegate, for your testimony. Next, we have Mr. Alan Berman.
Sorry.
I'm so sorry. I believe that there is a hearing in the Senate on this very bill happening today, so it might be we might have some difficulty getting them over here in time.
So do we have Paul Nestat, Michael Eagle, Eileen Zeller?
I am here.
Okay, wonderful.
Yeah, it would be wonderful if we could get your the other witnesses because they were going to give the substance of the testimony and talk about the surveillance and trends and things like that. I was going to kind of put the icing on the cake, which I'll do anyway, but Delegate, yeah, I know you will.
Why don't you get started
you
and we'll do our best.
I will do that. I will do that. So my name is Eileen Zeller, and I retired from the federal government Substance Abuse and Mental Health Services Administration, SAMHSA, in 2018, where I was lead public health advisor in the suicide prevention branch. In that role, I had a perspective on suicide prevention policy and practice across the nation. And in retirement, I serve on the Governor's Commission on Suicide Prevention and the board of the Mental Health Association of Maryland. But today I'm representing myself. And having thought that the previous folks were going to give the basis of this testimony, what I want to do is kind of expand on Delegate Belcastro's discussion about Oregon and the impact that suicide fatality review committees can have on a state. So she talked about the wonderful pet shelter story, which has made an impact. Oregon also identified eviction as a major risk factor. And as a result, law enforcement began adding crisis line information to the eviction paperwork that they had to put in. Also, every time there was an eviction, a member of the mental health crisis response team was sent to every eviction to support the people there. Within 2 years, they reduced eviction-related suicide from 30 to 1. So this is another example of, for minimal cost, how data can lead to improved practices and policy. Another real quick one, in New Hampshire, the team learned that a significant number of adults who died by suicide did so within weeks of being discharged from an emergency room. Sometimes that was for a suicide attempt, sometimes not. That was several years ago. As a result, nearly 100% of state emergency rooms now conduct universal screening for suicidality. There isn't time, but please do read about the Gunshot Project, which is another innovation that, that New Hampshire started as a result of their fatality review. I thank you for your time and urge you to approve this bill. Thank you.
Thank you so much. Do we have Mr. Berman or Mr. Nestat or Mr. Eagle?
Hi, this is Dr. Nestat.
Wonderful. Good afternoon.
Good afternoon. I should let you know that Dr. Berman and Mr. Eagle are both still on the Senate hearing of this bill. I just left early to join you here.
Wonderful.
So
Why don't you give us your testimony?
Sure. Just on my phone while I'm on both Zooms at the same time. So my name is Paul Nestat. I'm a psychiatrist. I'm an epidemiologist at Johns Hopkins. I'm a member of the Executive Board of Maryland Psychiatric Society, and I'm also a consultant for the Governor's Suicide Prevention Task Force and co-chair of the Hopkins Suicide Prevention Work Group. So recently, a freshman at Delaney High School in Baltimore County died by suicide. Suicide is the second leading cause of death in Americans under 40. And so youth suicide is unfortunately not rare in Maryland, but I've been tracking this case because my family went to Delaney. I'm still connected to the community, and I've watched how it's been reported. And it's been really interesting to see how, for instance, among Maryland psychiatrists on our private servers, there's a lot of talk about how lack of access to mental health care for kids especially might be to blame. When Fox 45 did their report, they concluded that there was the pandemic school closures that were to blame. But most heartbreakingly, they quoted the young man's father as he was trying to make sense of the unthinkable. He said, "I'm trying to see what I missed," his father said. He said, as a father, as his advocate, as his protector, what did I screw up? So as experts, we don't have very much to offer these parents to help them understand what was going on, because unfortunately, we do very little to investigate these deaths beyond just determining the cause and manner at the medical examiner level. Suicides are always going to generate these kind of questions, both for loved ones and for scientists and physicians working to prevent them. I'm actually going to skip ahead and realize I only had a minute. So let me say that the Suicide Prevention Review Board has the potential to provide.
You know what? You can slow down. The delegate had at least, a minute left, so you can have an extra minute.
Okay. Well, I'll just say that in Maryland, the suicide rate's gone up 30% over the 21st century, 18% just in the last 5 years. We know that suicides are going up in 2020, especially among Black Marylanders. And this is a population where we know even less about the proximal risk factors and things that we can do to intervene. So having the suicide prevention Review Committee will allow us to understand more about these deaths, because unless we understand what was going on, unless we can identify patterns that have led to these deaths, we can't intervene appropriately. We're sort of fighting blind. There's things that the review committees can identify. We've seen in other states. Dr. Zeller might already have gone into this. One thing that I noticed as a really important thing early on was the little subtle patterns that are picked up. In Florida, they have a suicide fatality review team that looks at a few deaths and noticed there were a lot of people that were going to the ASPCA to give away their pets before they died by suicide. Something that wouldn't have occurred to me as a suicide epidemiologist, but turned out to be a really common theme. So they implemented a series of interventions where they put, first just posters with suicide crisis hotlines in, ASPCA pet drop-offs, but then actually targeting when someone seemed like there was something off at drop-off, targeting them with more intense interventions. This can be really effective, and we can only know about these patterns if we have a review board. So just overall, I want to point out the fact that there's no more economically sustainable or cost-effective way of stopping suicide in Maryland or preventing suicide in Maryland. We know that suicides are responsible for close to $1 billion in work and medical costs in the state of Maryland. And by fueling any intervention that is appropriately targeted, we can lower that number. So I just want to support this bill, and I'm happy to answer any questions that anyone on the committee has. Thank you.
Thank you. And thank you for your time. We really appreciate you. So we don't have Michael Allen, but because it's scheduled on, at the same time, when they come in, you have my word, we'll take the next bill. Then after that bill, they can also give their testimony, okay?
I can just let you know the Senate just closed 5 seconds ago. I'm watching the other Zoom, so they might be joining any second now.
Okay,
Oh,
wonderful.
I just allowed Larry Berman and
Beautiful.
Mike Eagler should now be joining the.
Oh, wonderful. Mr. Berman, good afternoon. Will you be so kind and unmute yourself and let's hear your testimony?
Thank you, and I appreciate you giving me the opportunity to testify. We were a little late on the Senate side.
It's okay. We will wait for you. Thank you so much. We really appreciate it.
So my name is Lanny Berman. I'm an adjunct. Oops. Something's happened with our video. Can you hear me okay?
Yes, we can. We can hear you perfectly.
Okay. So I'm an adjunct professor in the Department of Psychiatry at Hopkins. I am a former executive director and past president of the American Association of Suicidology and of the International Association for Suicide Prevention. Prior to all that, I was director of the National Center for the Study and Prevention of Suicide at the Washington School of Psychiatry. So I've spent roughly 50 years spending my professional career in the study of suicide and the prevention of suicide. We know a fair amount about suicide from data supplied by the Centers for Disease Control and the National Violent Death Reporting System. But there is a great deal more we need to know and could know by virtue of this bill. We know, for example, that almost 1/3 of females who die by poisoning, suicide in the state of Maryland, but we know nothing about whether they were, whether they took illicit or illicit drugs, whether they were over-the-counter medications, whether they were prescribed, and whether the individual decedent was adherent to taking as prescribed. We know that about 1/3 of those who died by suicide in Maryland had made a prior suicide attempt, but we don't know anything about how recent that attempt was, what the responses to that attempt were, whether help was given or not, what the warning signs were. We know that about 1/4 of people who die by suicide disclose their thoughts to others, but we don't know to whom. We don't know what the responses were. We don't know what the missed opportunities for intervention could have been. This bill would allow us to interview knowledgeable informants, to integrate data from medical and mental health caregivers and from social services. We would learn about the sexual orientation of suicidal decedents, about which we now know nothing. We would learn about barriers to care and how we could overcome them. We could learn about warning signs. We could learn how to reach people who desperately need our help. And we can't do that with the data we have now. I desperately urge you to support this bill. Thank you.
Thank you for your testimony. It was perfect. Next, we have Mr. Michael Eagle. Good afternoon, sir. Is he in?
Yes, I'm here. I'm trying
Oh,
my video to start. Hold All right, here we go. All right. Thank you for allowing me to testify, Madam Chairman.
Our pleasure. You can get started.
Hello, I'm Mike Eagle. I'm a retired staff sergeant from the United States Army, a retired active Baltimore County firefighter, and I'm currently the IT director and the custodian record for the medical examiner's office. I'm currently here not representing the office, but representing me. And you're going to say, why? This year, I was touched by suicide, not once, not twice, but 3 times, in all 3 occupations. As a soldier, I lost a staff sergeant from suicide. As a fire specialist in the fire department, I lost a fire captain from suicide. And my daughter lost a classmate from suicide. That touched me. I immediately got involved with the Certified Committee for Suicides within the Department of Health and with Paul Nesmith. We've been working together to figure out what are the warning signs that we could have done to fix this pandemic. And I use the word pandemic because all of them had no signs. No one knew anything and no one cared. So as a father, I said, I have to help. As a soldier, I said I had to help. And as a firefighter, I have to help. So please let me help. Please give me the tools to allow these care providers to help figure out what's causing this and what can be done to solve this problem. Thank you very much.
Thank you for your testimony, and I'm so sorry for your losses, okay? Are there any questions for this panel? I see Delegate Collison.
Thank you, Madam Chair. Thank you, Delegate Pocrastro, for this bill. It's such a timely bill. I was looking at the makeup of the group, and I wondered where you got, how you put that makeup together, and if there's any flexibility in the makeup in terms of the kind of work that it has to do. So just talk to me about the composition of the group.
I noticed in the testimony that there were some suggestions and that people were suggesting for the makeup of the committee. I'll say that we're open to amendments and we're open to looking at the makeup of the committee.
Great, thank you.
Thank you so much. The following delegates have questions as well. Delegate Shalega, followed by Delegate Semple Hughes. Good afternoon.
Thank you so much, and thanks,
My pleasure.
Castro, for bringing this bill. It's important that we look at suicide. I was reading the bill, and I noticed in your whereas clauses, which obviously are just the preamble to the bill. You say every year in the state, an average of 530 persons die by suicide. More persons die by suicide than by homicide. But I found that 542 people had died by murder. So I think you may need to look at that and see if that needs to be corrected. I believe more people are murdered than commit suicide.
I definitely appreciate that. We'll take a look at it and see what adjustments need to be made. I appreciate you bringing that forward.
Okay, and I had another question. On page 5, the department shall provide staff for the state team. I was wondering, you're asking the Department of Health to staff this?
Yes, we are.
And I noticed in the fiscal note, it said 2 additional employees. Is that what you're asking for?
Yes, so that is what we're asking for. Do you have any specific concerns with that?
While I think this is important, I'm wondering if today, while the Department of Health is so bombarded with COVID and getting vaccines in arms and all of the challenges that we have, if this bill might be better looked at next year after we get through the pandemic.
I'll just say that we are definitely open to amendments, and I definitely appreciate the concerns that you brought forward today.
And I have one final concern on page.
We're only allowed one question, Delegate, but
Okay, all right, thank
I
you.
will allow it, but only for the rest, only one question, okay?
Okay, page 7, I'm concerned about just in general, some of the HIPAA problems. I have a family member, close person who did commit suicide, and I can tell you that the family would not want to talk to people, nor have somebody get the power to look into some of the issues that the bill is giving power to people to look at. So are you going to let the family members have a determination on whether that happens or not?
I'm going to defer to Dr. Nestat for that. Do you have any more insight
Yes.
on this to give to Delegate Shalega?
Yeah, of course, this is voluntary. No one would be compelled to talk to the investigators, to the usually psychologists or psychiatrists that be talking to them. I've found in my experience that most families are very interested in talking to anyone that can help them make sense of what happened. But it would only be if they're willing to. Other aspects, for instance, looking through medical records, these are the things that the medical examiner already has access to, things like CRISP, our Chesapeake Regional Information Systems Portal, but doesn't have the resources or time to go through. But yeah, we wouldn't be forcing anyone to be interviewed, of course. And it's something that I should say, there's research that shows that when you do talk to people in what we sometimes call psychological autopsies, forensic interviews after a suicide, it can be, for many people, therapeutic and help them with the grieving process. So yeah, just the short answer is we're not forcing anybody.
Okay, and it'd be nice to have that language in here that allows families to opt out so that you can't get the health records if the family doesn't want to be included. Thank you.
You're welcome. I want to remind the members that you can only ask one question, and also please show your video. I mean, we must see you. Those are the rules. Next, we have Delegate Sample Hughes.
Thank you, Madam Chair.
My pleasure.
Thank you, Delegate Belcastro, for this bill. Very important. Unfortunately, my good friend, he committed suicide on my birthday a few years ago, and I'll never forget that day. But I look back at the signs and just really wanted to document it in some fashion. My question is for Berman. You had mentioned about the medical examiner, the poisons that could potentially be known as a result of this. So does the medical examiner already have that ability to share this information, or this bill would provide them the ability to share this information? I just wanted to understand how involved is the medical examiner in this proposed legislation?
Sorry, I didn't know if that was directed to me, so I'll answer.
Whoever you think is the best. I knew you referenced it, so that's why I said your name, sir.
So we currently, through the medical examiner, can get toxicology studies that are done on at least most all, if not all, poisoning deaths. What we don't learn, however, is what is not in a toxicology report. And that is how the individual had gained access to the medications or the poison. Again, if they were prescribed medications, to what extent the individual had been taking them as prescribed, which is crucial information in terms of understanding how caregivers, be they primary care or mental health caregivers, can better stay on top of the people they're treating who otherwise have suicide risk. There's a whole range of information about medications and the mechanisms of poisonings that we simply do not learn simply from toxicology studies.
Okay.
Thank you. Next, we have Delegate Chisholm.
Thank you, Madam Chair, and thank you, Delegate Belcastro, for bringing this bill. I do think it's vitally important, and I think time is of the essence. My question to you is, and I don't know if this was brought up in the testimony, but is this is this model being used in other states? Unfortunately, this is a nationwide problem. And if so, do you know what type of results they're getting from those other committees or those other studies? I'd be curious to see that, if you could provide that. And if somebody can speak to it, I'd really appreciate it.
Thank you so much for the question. I'm going to defer to Eileen Zeller because she provided a lot of different examples in her testimony about what other states are doing.
So I don't know how many states are doing this right now, but I can tell you that there are numerous examples of how states have used the data to find intervention points and prevent suicides. I mean, I have 5 listed in my written testimony, including a gun shop project, which is something that New Hampshire discovered, I don't know, maybe 7 years ago or so, where they found that out of 144 suicides in a 2-year period, nearly 1 in 10 used guns that had been purchased or rented within a week of the suicide, sometimes within hours. But instead of turning this into, you know, a gun control issue, what happened was that one of the gun shop owners, who was very, very disturbed that within a week, 3 people had bought firearms from him and all died by suicide within 2 weeks. He worked with some public health and suicide prevention experts. They started what's known as a gun shop project, which has since spread to 20 different states. And in fact, Baltimore County right now is considering starting, it is trying to start one. And they work with gun stores, firearm ranges, about training staff and how to identify people who are just not acting the way a normal person would act if they're purchasing a firearm. And they have prevented numerous suicides like that. So there are many, many examples. I don't know that there's a national report that would be comprehensive about that. This is what we would call a current best practice with a lot of evidence behind it.
Thank you very much. I greatly appreciate the answer.
Thank you so much. And we have Delegate Lewis Young.
Thank you, Madam Chair.
My
I would
pleasure.
like to direct my question to Delegate Belcastro. Delegate, have you had an opportunity to speak with the authors of the fiscal note? I know typically they come out at the very last minute, and although they've had input from the staff function, they may not have clarification from the bill author, which could dramatically affect the fiscal note and provide greater accuracy.
I appreciate you raising that. I did recognize with the fiscal note did just recently come out. I did notice it was rather high. We have not had the opportunity yet to connect with them on it.
Thank you.
Thank you very much. So I don't see any other questions on House Bill 209. Delegate, thank you for your testimony. And it was the first time testifying, I believe, this session. So thank you very much for the witnesses. You did a great job. And that actually concludes the bill hearing on House Bill 209. Next, we have House Bill 318, Delegate Lewis Young, Developmental Disability Administration Self-Directed Services. This is the Self-Direction Act. Delegate Lewis Young.
Thank you very much, Madam Chair.
My pleasure.
In a more ideal world, this bill probably wouldn't be necessary because in 2005, Maryland created the New Directions Waiver, an Independence Plus program that allowed individuals with developmental disabilities to direct their own lives and care, allocate their funding, and hire their own employees. Unfortunately, since 2013, the aspects of this program have been systematically walked back, and subsequent and significant changes limiting self-directed care have been put in place. And much of that is documented by very extensive audits. So what this bill does is three things. It simply restores the original intent of the 2005 program by again empowering participants to self-direct their own care. And it provides a definition of self-directed care, which will be codified into law, and it will ensure individuals living with developmental disabilities the ability to direct their own lives. Secondly, it establishes support brokers to help individuals living with developmental disabilities to self-direct their care. And finally, it creates an advisory council to ensure that any issues with self-directed care are resolved. Madam Chair, I'd like to give the remainder of my time to Alicia Wopot, and be followed by Carol, Ginger, Sunny, and Patty.
Thank you, Delegate. So Ms. Alicia Wolpak, will you be so kind to testify, please?
Thank you. I am the president of Self-Directed Advocacy Network, SDAN, an all-volunteer advocacy organization, and I'm the proud mother of a son with autism who is in his 5th year of self-direction. I hope you all have had an opportunity to view our video and read some of the stories from SDAN members who are asking for your support of this bill. It's really important for you to know that the Federal Centers for Medicaid and Medicare Services, CMS, defines self-directed services as allowing participants to have responsibility for managing all aspects of service delivery in a person-centered planning process. Self-direction promotes personal choice and control over the delivery of the waiver and state plan services, including who provides the services and how they are provided. Participants are afforded the decision-making authority to recruit, hire, train, and supervise the individuals who furnish their services. The CMS allows states wide latitude in how they implement these programs, and Maryland's DDA is moving away from allowing participants to control how and by whom they receive supports. Self-direction has been severely curtailed here in the last 6 years. Nothing in this bill jeopardizes federal dollars. Our bill seeks a restoration of previous levels of choice and control, where incidentally, all federal matching funds were available, contrary to the MDH contention. An option that was once individualized, person-centered, and efficient is morphed into one that is ever more standardized, state-centered, and costly. Policy and procedure changes have included some of the following: elimination of overnight supports as a self-directed option. What is now offered is an agency where you lose control over who is hired to provide supports in your home. Elimination of individualized transportation arrangements so people have funding to get to their community activities. Severe restrictions on funding for activities and therapies, such as music, art, and riding. Future elimination of choice and control and competition for essential fiscal management services when choice increases quality and decreases cost. Restrictions on who's even eligible to self-direct. Restrictions on the participant's team choice to hire family members when it's in the participant's best interest and their preference. Restrictions on the amount of the scope of the assistance of the support broker, the only real professional on the team with a fiduciary duty strictly to the person. Support broker roles have been shifted to overburdened and undertrained coordinators of community service or CCSs. Creation of dysfunctional methodologies and procedures that are hurting participants by causing confusion and delays. Contrary to MDH's opposition letter, the 4% COLA that you all voted to give all DDA participants has not been given to most of the self-directing participants for FY21, 6 months after the fact. It is certainly not duplicative. At a minimum, 59% of our members do not have it. The mere 14 who have received the COLA expressed that they really had to fight for it, citing repeated requests and conversations with their CCS and DDA directly. In conclusion, and most importantly, none of these restrictions and eliminations are due to the CMS rules. They're Maryland's DDA choices, and none of the aspects of HB 318 put the federal money in jeopardy. I also want you to know that we haven't taken this lightly. SDAN spent thousands of hours of time, attended every meeting and work group that DDA's invited us to, every time. We've responded in writing with public and private comments, feedback, and recommendations, written emails of concern in numbers too high to count for 4 years. SDAN's met with Secretary Beatty, Deputy Secretary Simons quarterly, and now monthly, and will continue to do so. We've joined 7 other disability advocacy groups in regular meetings with then Secretary of Maryland Department of Health, Robert Neal, to try to right these wrongs. And although mandated to seek input as the MDH letter does state, DDA has heard much from us, but they rarely listened. So here we are with a less flexible, less person-centered program that has left its participants with less choice, less control, and some in jeopardy of their health and safety. That's why, along with us, other advocacy groups are supporting this bill. ARC of Maryland, DD Council, Disability Rights Maryland, just to name a few. And we're asking for your support too. Next, I believe you'll be hearing from Carol Custer, SDAN board member. Thank you very much.
Thank you for your testimony today. Ms. Carol Custer.
Hello, I'm an SDAN board member and volunteer and a professional support broker for over 20 people. I have always fought for their best interests, but I have never made a decision for them, nor have I ever authorized my own payment. With his and his family's permission, I will tell you about Desi. His story illustrates both the human and fiscal costs of DDA's version of self-direction. Desi was a preemie with multiple disabilities. In 2005, he was one of the first in Maryland to get into self-direction. It gave him choice and control of his life. Desi's parents, now in their 70s, have always freely given many of the 24-hour supports he needs to stay safely at home. Aware of their own mortality, they sought to ensure continuity of the routine that has given Desi security, well-being, and joy. They worked hard, saved their money, and provided him with a small home. They retained dedicated staff who have worked for him for years and years and years. In January 2020, Desi sought more support so he could move into his home. He needed just $24,000 more per year. Despite demonstrated need, DDA denied his request, citing cost effectiveness and new restrictions on personal and overnight supports. DDA's alternative, all but 40 hours a week of Desi's staff must become an agency employer at a lower pay rate, putting him at risk for losing these consistent, dependent employees. The actual price tag of this cost-effective supportive living option, at least $44,000 more than Desi's initial request. The actual cost to Desi, little say in who helps him go bowling, fix dinner, or use the bathroom. Little say in who is with him when he wakes at night, thinks it is day, and tries to leave the house. Little say in the self-directed life he chose for himself in 2025. Thank you for your time.
Thank you for your testimony. Next, we have Ms. Ginger Houston.
Yep. Hi, my name is Dr. Genevieve Houston Ludlam. I am a volunteer board member of the Self-Directed Advocacy Network. I'm also the mother of Carmen, my charming adult daughter with Down syndrome who self-directs her DDA Medicaid waiver services. I'm here to present you with the data supporting SDAN's concerns. You have heard testimony stating that self-directed services, along with being a more person-centered way of delivering services, is also more cost-effective. We received anonymized budget data from the DDA through Freedom of Information in December of 2020, making this a very current snapshot of currently active Medicaid waiver service budgets. The average budget for people self-directing their Medicaid waiver services is about $65,000, compared to an average budget of about $89,000 for people receiving traditional provider-managed services. On average, the self-directed model delivers a 27% cost savings to the state of Maryland while providing tailored services to the individuals out there living their best lives the way they want to live it. Win-win. Finally, if you have heard about problems we are having with the DDA, including timeliness of budgets, lack of communication, and non-responsiveness. SDAN conducted a survey of their membership on these issues in December of 2020. 60% of our survey respondents said they were having issues with plan approval or updates. Right now, 24% of self-directed plans have not yet been approved by the DDA. In the comments, most respondents cited delays and lack of responsiveness from DDA as their main issues. Let me conclude with briefly sharing my own personal experience with these issues. My daughter Carmen transitioned from school-based services in July of 2019. For 6 months, she was left without her waiver services because DDA did not get her budget approved. In fact, the only reason it did get approved was that I contacted the governor's office and the Maryland Department of Health. The next July, her new budget was supposed to begin. It was not approved until September, and only after I threatened to go to the governor's office again. Thank you. Now you'll hear from Sunny Sefarati, one of our SDAN board members and a self-directed participant.
Ms. Sefarati.
Good afternoon. Thank you, Madam Chair. I am a self-directed services board member. I'm an SDAN board member, and I am also the co-founder of the Musical Artist. I just want to ask, I am completely blind. I'm just wondering if everybody can see me. My video is on, like you requested, Madam Chair.
We can see you clearly and we can hear you beautifully. Thank you for being here. You can proceed.
Yes, ma'am. So I am an SDAN board member and I am co-founder of the nonprofit organization called the Musical Artist. Upon graduating from the Maryland School for the Blind in 2007, I was placed in a sheltered workshop where I remained for 8 years. I started self-direction in 2016. My support broker, CJ Shiloh, who is also the co-founder with me on the Musical Artist, helped me get out of the sheltered workshop. Not only do I serve on the Musical Artist Board, but I also serve on the Maryland Developmental Disabilities Council and the Self-Direction Advocacy Network Board. If CJ had not helped me get out of the sheltered workshop and start serving on these organizations, I would still be there. DDA definitely needs to be accountable. And I believe that the advisory council, if this bill is passed, would make DDA be more accountable for some of the miscommunication and some of the issues that we've had. Self-direction has definitely had a positive impact. And being in the sheltered workshop for 8 years was pretty bad because I had to work under the mercy of someone else rather than take charge of my own services. So self-direction has really changed my life. And I just want to give credit to CJ, who is my support broker. And I just want to say that she has done a really good job helping me find this program, and it's working. Thank you for your time, Madam Chair.
My pleasure. Your timing was wonderful. Next, we have Ms. Saylor. Is Ms. Patty Saylor?
Yes, hi. Thank you, Madam Chair and committee members. My name is Patty Saylor. I'm an RN and I've been working for people in self-directed services since its inception 15 years ago. I've worked for almost 100 different individuals and their families over that time period. I've witnessed the impact of the changes that DDA has made over the last 5 to 6 years. I chose to begin volunteering with the Self-Direction Advocacy Network to represent the needs of my customers, many of whom are consumed with the demands of their lives and rely on advocates to convey their concerns on their behalf. I was going to illustrate to you the negative impact changes that have happened to people, but I think you've heard that. I instead want to tell you about the human toll that I witness. In the course of my job, I speak at length with my customers and their families. We laugh and we cry, and I tell them that it's going to be okay when they're no longer here, that we will protect the system so that it will be here when they are not. On a daily basis, I see firsthand the pressure they're under. Families are our best natural resource. The state should value and protect them as much as we can. They continue to take the lion's share of financial and physical support of their loved one. Their love of their adult children or their sibling should not be exploited by the government. While they are grateful for any and all supports they get from the state, and grateful even more so for the flexibility during the state of emergency, they are exhausted and frustrated and angry and fearful. They are fiercely protecting themselves and their individuals from the virus. They're taking on the role of direct support so staff do not come in and out of their home. They're under economic and work pressures. They have very little sleep and no respite. And on top of that, they must deal with the ever-growing bureaucratic red tape systems from the Maryland Department of Health and DDA that do not work, policies that limit their choices and control over their own lives. They must simply passively endure if they want services. Or it may even be suggested to them that perhaps self-direction isn't the right choice for them, when for most of my customers, it is the only choice. Thank you for listening.
Our pleasure. Are there any questions for this panel? We have Delegate Kelly, followed by Delegate Kerr. Delegate.
Sorry, I had to unmute and I got distracted. I apologize. Thank you very much for this bill. My question is really simple. I was reading the opposition, and let me just note that I have constituents who are deeply concerned with this issue, so I know how important it is. But I was reading the letter from the Department of Health and really just wanted to ask your opinion on what seem to be their two main points of opposition. One is sort of that it would pose operational challenges, and the second is that evidently, they believe that the federal money would be in jeopardy, that there's a rule from CMS that prohibits support brokers from having a fiduciary duty. So I know someone touched on this briefly when explaining the bill, but if you could tell me a little bit more about why you think that's not true, that would be helpful to me.
And only one person can answer from the panel, so your best person.
Okay, well, this is Carol Custer. I don't know if I'm the best, but I'll give this a shot. So there is nothing in this bill that will jeopardize the federal match. Everything that we're requesting has already been done in Maryland and approved under other waivers. So that we disagree with that completely. And CMS guidelines actually states that another term for a support broker could be a personal agent. Agents of individuals usually do have a fiduciary or do have to act in their best interest. We picked the term fiduciary duty in order to not call us the primary advocate anymore, because individuals are their own primary advocate, but the new directions waiver started in 2005 used that term. So we were just trying to come up with a way that showed that your obligation as a support broker is to work for the best interest of the person. It does not conflict with any CMS guidelines. And I think by use of the term personal agent services, they've kind of make that clear. As far as oversight of support brokers, there really is no additional need. There's a team of people. They can be fired at any time by the participant, and they do not make decisions. As a support broker, I can guarantee you I have never made a decision for a person. But they do need a professional who understands the system as best as possible these days and helps the families navigate this very user-unfriendly system. And I'm sorry, there was a third part to the question, and I'm not sure I addressed it.
Actually, that was a really good answer to my question. Thank you so much.
Okay.
Thank you, Delegate. Next, we have Delegate Kerr, followed by Delegate Bill Castro. Delegate Kerr.
Thank you, Madam Chairman. Delegate Lewis Young, let me follow up on Delegate Kelly's question with you, as I believe you're a member of the Joint Audit Committee. According to the concerns that the Maryland Department of Health has here, that portions of this bill would be contrary to the Office of Legislative Audit's recommendations, and then also what Kelly mentioned about creating unreasonable operational challenges. Will you please address those for me?
Okay, I can speak to the audit comment because you're correct. I am on the audit committee. And in fact, when I read that comment, I went back to months of audit reports, which are extensive on DDA. I could not find anything. So what I did was I called and emailed Greg Hook, who is the chief auditor. And I said to him, what am I missing? I shared that comment. And I will share a very brief response that he sent to me. I had OLA staff who were involved with the last DDA fiscal compliance audit review HB 318 and the prior audit report, and they did not find any audit issue that we believe provides support for MDH's assertion that this bill is contrary to the recommendations of the Office of Legislative Audits. At this time, it's our opinion that MDH may have misunderstood prior report findings 3 or 4, and that could be the basis for MDH's statement. We are attempting to reach out to MDH officials to obtain clarification on their position, but might not be able to do it before the hearing. So I don't know if that happened. I'm not sure if I'm the best person to speak to the operational difficulties, but I will say, as I mentioned in my intro, there are basically 3 aspects to the program. The self-directed aspect was instituted in 2005. And the advisory council should not be significantly different from the quarterly SDAN meetings. SDAN stands for Self-Directed Advisory Network. You've heard many of the board members refer to that. They are supposed to meet quarterly, but my understanding is DDA has cut that back. So I think the advisory council would take the place of that, but perhaps through another question, one of the other advocates can correct me if I'm wrong. Thank you.
Thank you, Delegate, and thank you, Madam Chair.
My pleasure. Next, we have Delegate Bill Castro.
Thank you, Madam Vice Chair. Delegate Young, I'm going to reciprocate the question that you asked me in my hearing. I looked at the fiscal note and I was wondering if you had the opportunity to look at MDH's projections for the $3.3 million fiscal note.
I have, but Madam Chair, with your permission, I'd like to defer that to somebody else that has been working with the program for numerous years.
Go ahead. Who is that?
Okay, that's me again, Carol Custer. So we are actually very confused by that fiscal note, and we would ask for more clarification from MDH in order to adequately respond to it. But $3 million in programming cost is kind of confusing because they have to enter these people into the LTS system regardless of whether they're under this waiver or any new one. The advisory committee does not, or a bill does not require that a new waiver be created. It is just an option in order to get the characteristics of self-direction returned to Maryland. Since merging the self-directed and community pathways waiver into one back in 2013, DDA has created 2 additional waivers, the community supports waiver and the family supports waiver. So we're kind of confused if the costs were so high to create an additional waiver, why that was done. And we're also confused about why additional staffing would be required to administrate the program, because there is already a statewide self-directed coordinator and 4 regional directors, coordinators of this service. We do not believe any additional staffing should be necessary. And then regarding the amount of time of the staff created by the council, in last year's fiscal note on this same issue, the DDA stated, or the MDH stated, that the advisory council should not let's try this again. Stated that the advisory council could be staffed by would not need to be staffed by additional support. Sorry, I didn't type that correctly. There would be no needed additional support. So this aspect of the bill should not be changed. We also, as Delegate Young said, we meet with them on a regular basis. It was quarterly since 2018. And actually, they have increased the number of our meetings. And starting this month, they are going to be monthly. Before and during the COVID crisis, SDAN has met regularly with Secretary Neal about self-direction issues, along with the 7 other advocacy groups. The council would probably eliminate the need for many, if not all, of these meetings. Regarding their comments about the time and energy required to write or amend a waiver, because we are very heavily invested in this process, and we agree it is very time consuming. SDAN provided detailed comments each of the 6 times DDA has renewed, amended, or tried to amend the waiver since SDAN began in 2016. The current waiver renewed July 1, 2018, and Amendment 3 to that waiver was just approved by CMS this month. Unfortunately, very few of our recommendations rarely appear in any of the 6 waiver revisions that have come since we were in place. Again, sorry, I'm not the best public speaker.
That was fine. Thank you. Next, we have Delegate Hill, followed by Delegate Semple Hughes.
Thank you, Madam Chair. And I think this would a question for Ms. Custer again. I just want to clarify again, looking at the department's letter. As far as you are aware, since the self-directed program was originally done and carried out, as I understand it, ways that were very helpful to the clients, there have not been any changes in federal law that would prohibit Maryland from doing what they used to do. Is that
That's correct. The CMS guidelines were updated from in 2019, but nothing substantial changed in relation to self-direction.
Thank you, Delegate. Next, we have Delegate Semple Hughes, followed by Delegate Lewis.
Thank you, Madam Chair. Very quick question, but I just wanted to get clarity on how would the licensing requirements provide a risk? I don't know if Delegate Young would answer that or someone else on your panel. I know it was referenced, but I just needed to get just a little clarity.
I think that's me again. I think I'm the designated question answerer today.
You're doing a good job.
We'll see. We agree that providers need to be licensed. Our bill does not call for unlicensed individuals to provide services. The legislative analyst correctly understood our bill when stating in her analysis that MDH may not require a person that is authorized to provide services to a recipient in the state to obtain any additional approval to provide the same services to recipients who use self-direction. All we're saying is please do not put another roadblock in the way of getting services. If you're licensed to provide services in the state, you should not have to become DDA certified or licensed on top of that.
Okay, thank you.
Thank you. Next, we have Delegate Lewis.
Thank you, Madam Chair. Hope you guys can hear me. Yes, okay.
We can hear you.
Thanks, Madam Chair. Thank you, Delegate Lewis Young. My question is about the Advisory Council. How is it different from the oversight meetings that are already happening? What does it offer? What's the value add?
I guess I could take this one too. The value add is that it is going to require that DDA work with the council to establish a waiver that returns us to the principles of an independence plus waiver that the New Directions waiver that was in 2005 provided to the state of Maryland. And it also gives us the opportunity to report to the legislature about the issues that constituents and stakeholders are having with the Developmental Disabilities Administration on an annual basis. And in the hope that with your efforts, we can hold them accountable for the decisions that they're making on behalf of the citizens of Maryland that have actually been harmful to many of those citizens.
Thank
We're
you.
hoping it gives us some teeth, in other words.
I don't see any other questions. I do have one. When we met with you, the committee last year, the concerns that you raised, are they in this bill? Delegate Young?
One of them is, oh, you want her to answer or me?
Well, if you can answer it, go ahead. You seem
Young,
to
you want
be
me to?
doing very well. Go ahead.
Okay. Okay, the only concern that's in this bill is related to making the fiscal management service a choice. That contract was to award fiscal management service to one provider. And the way it was written, it was pretty much geared to a large national provider, which would have eliminated the ability of the two Maryland companies that provide it now to remain giving service to providers. And it would have absolutely taken choice away. We feel that those providers from Maryland have done a phenomenal job holding this all together during the chaos that's been created in DDA in the last 5 to 6 years. And we just want to see that choice is maintained in Maryland for that very important service. Unfortunately, it seems like the DDA still intends to move forward with an RFP for hopefully not for one provider, but at least through an RFP process. It is not necessary that it be done that way. It could be a service, just like personal supports or community living or nursing services that's covered as a waiver service open to as many providers that are qualified to provide it.
Thank you, Ms. Custer, and you did beautifully today. There are no other questions. So thank you so much for your testimony. Now we're going into the unfavorable panel, and we have next Mr. Bernard Simmons from the DDA.
Hi, can you hear me?
Good afternoon, sir.
Good afternoon. Can you hear me okay?
Absolutely. We can hear you and see you. Thank you.
Okay. Well, thank you for the opportunity to
Our pleasure.
Be here and to present some issues that DDA has some concerns. You know, it's correct that we've been meeting and we've had the opportunity to have Secretary Beatty meet with us on a quarterly basis. And I've actually had a discussion with Alicia Wolpat, who's the president of SDAN, to move forward with doing these monthly. You know, I've been committed to self-directed services since I got here in 2014 and heard a lot of issues from participants and families about having some difficulties in finding staff and be able to recruit, to advertise, etc. And as a result of that, I added $500 to each participant's budget so that they can move forward with being able to recruit and interview, etc. When they started here in about 2005, there was about 41 individuals that participated in self-directed services. When I started here in 2014, there was 350 people enrolled in self-direction, and I committed to making sure that it was an available model, because all I had heard initially when I got here was if I can't find a provider or a provider won't provide supports to my loved ones, I am forced into self-direction. That is not a good plan at all for anyone. And so I did commit. I said we would do this. And as of last month, December, we enrolled 1,266 people. So that's an increase of 261%. So I'm not so sure that some of the comments that we've heard earlier today, and I don't mean this personal to the folks, but, you know, I hear things, we try to address them. It's not a perfect system. I understand that. That's why we meet with the SDAN group, et cetera. But there's got to be something positive to it when we had a 261% increase. And I want to continue to enhance this model and move forward with it. Again, we've had our meetings, and then looking at this House bill, it includes some changes to the delivery model that are contradictory to the Center for Medicare and Medicaid Services in the technical assistance guide. And, you know, if we move forward with this, and the bill and says, DDA, you should create another waiver. I'm not so sure some of the elements would even be approved by CMS. So as an example, in earlier testimony, there was some discussion about you can't do
Sir,
music.
you have to start wrapping up, please. Your time
Okay,
is
so
up, please.
all right. So the bottom line is that we don't support this. Fiscal management services is an administrative function that needs to be conflict free. It can't have any interference or any influence by people who are support brokers.
Thank you very much. Thank you.
Okay.
Thank you so much. Are there any questions for this panelist? One second, please. Seeing none, that concludes the bill hearing. Thank you so much for being with us today. We really appreciate your testimony. That concludes the bill hearing on House Bill 318.
Thank you.
Thank you.
Our pleasure. Next, we have House Bill 28. I have actually three bills, 28, 309, and 78. I'm going to start with House Bill 28. And House Bill 28 is actually titled Public Health Implicit Bias Training and the Office of Minority Health and Health Disparities. So I want you to look at the fiscal note, and I want to say good afternoon. Thank you so much for having me, Chairman and members of the committee, and for allowing me to present to you House Bill 28. It is an honor. I would like you to look at the fiscal note and look at the appendix where it says health disparities. I mean, it's really clear that data consistently shows ongoing and in some cases growing health disparities in Maryland, including the impact of COVID-19. So in Maryland, out of the 24 jurisdictions, the jurisdiction with the highest number of COVID-19 cases is Prince George's County. The zip code in the entire state with the largest number of COVID-19 cases is 20783, which is the immigrant Latino community. So they have been devastated by this illness. Also, the maternal and infant mortality incidence of HIV, emergency room visits for substance use, asthma, diabetes, and hypertension. And if you keep reading, you see the disparities with Black and Brown. I mean, it is horrible and it is unacceptable. So House Bill 28 basically starts to take care of that by requiring, expanding the data reporting requirements of the Office of Minority Health and Health Disparities to include racial and ethnic data in their annual healthcare disparity policy report card. So there is a law that requires that this report card be done every year and published on the Department of Health website. But the last time that it was done was in 2010. So we need to fix that. The bill also requires that information be posted on the website and to update the data every 6 months. If you look at the data on the Office of Minority Health and Health Disparities website, the last reports are in 2013. It also mandates funding increase for the office. So basically, we want it to be permanent. You know, we have been underfunding public health, and it has to be a priority. It also requires all licensed and certified healthcare professionals to complete an implicit bias training course approved by the Cultural and Linguistic Healthcare Professional Competency Program. So we did this implicit bias training for maternal mortality last year. The bill actually went into effect this January 1st, and Johns Hopkins has developed a course. We're doing the same for all healthcare providers because the data calls for it and it is simply the right thing to do. I'm going to stop there because I have other witnesses and I would like to give my time to some of them. Thank you so much for allowing me to present to you House Bill 28. So the first witness we have is Ms. Shamanda Braithwaite.
Great, thank you. So I'm Shamanda Braithwaite, Director of Quality and Health Improvement at the Maryland Hospital Association. I appreciate the opportunity to testify in support of House Bill 28 on behalf of MHA's 60-member hospitals and health systems. MHA recognizes that racism is a public health crisis that contributes to inequities in access and quality and to disparities in health outcomes. Health equity is an integral part of our mission to advance the health of all Marylanders. Our commitment to racial equity informs the work we do with our Health Equity Task Force and our Diversity, Equity, and Inclusion Advisory Group to address the impacts of systemic racism on health. MHA supports the requirement in House Bill 28 to expand implicit bias training to providers across all healthcare settings. Implicit bias training, while not a panacea, encourages discourse and empathy in racially non-concordant patient and provider interactions, which can help improve communication and trust, contributing to improved outcomes. Under our total cost of care model, Maryland committed to reducing the rates of severe maternal morbidity, uncontrolled asthma in children, and the impact of diabetes over the next 3 to 5 years. These conditions are associated with longstanding health outcomes disparities by race and ethnicity. Implicit bias training for providers should be a part of the overall strategy to improve outcomes in those conditions. Another key part of the strategy should be to fund the Office of Minority Health and Health Disparities in support of its engagement in this critical work. Given its expertise, this office is an essential partner in developing and implementing statewide strategies to reduce disparities, and it should be given the opportunity, authority, and resources to carry out its mission. Thank you.
Thank you for being with us. Next, we have Dr. Kalyan Araman.
Thank you, Chairwoman Pendergrass and the committee members for this opportunity to testify. I'm Dr. Nilesh Kalyana, the health officer for Anne Arundel County, and I support House Bill 28. In Anne Arundel County, we began collecting and publishing race and ethnicity data for COVID just a few weeks into the pandemic in March 2020. The disparities we saw with Blacks having 1.5 times the rate of cases and deaths and Hispanics having 3 to 4 times the rate of cases was alarming. And in response to this, by the end of April, we had launched pop-up testing sites in communities with higher minority populations to address this disparity. As we continued through the pandemic, additional data showed that zip codes with higher test positivity rates also had higher minority populations, and we used this data to expand and refine the reach of our community testing. This is the power of data. It reveals patterns that then allows us to act. In November 2019, Anne Arundel County declared racism a public health issue. In July 2020, the County Department of Health established its Office of Health Equity and Racial Justice. We understand the importance of having an office focused on health outcomes for our most at-risk populations. And race plays a critical role in health outcomes. So publishing a report card from the Office of Minority Health and Health Disparities is going to provide jurisdictions with the necessary information to identify and address these disparities and monitor progress over time. Additionally, cultural competency and implicit bias training have the potential to contribute to improving health outcomes. Research shows that attitudes and behaviors of healthcare providers are one of a number of factors that contribute to health disparities. That's why it's imperative that health professionals have the skills needed to serve a diverse population. In conclusion, thank you for allowing me to offer my support of House Bill 28, and I think it's a necessary step to advance health equity in the state.
Thank you, Doctor, for being with us today. Next, we have Dr. Sharita Golden from Johns Hopkins.
All right, thank you, Chair Pendergrass, Vice Chair Pena-Malnick, and members of the committee. I want to thank you for your leadership on this very important issue and for allowing me the opportunity to speak with you today. My name is Dr. Sharita Golden, and I'm Vice Chair, Chief Diversity Officer, and a professor for Johns Hopkins Medicine. Health disparities have been a long-standing systemic problem in Black, Hispanic, and Indigenous communities. And as we've just heard, the COVID-19 pandemic has only further exacerbated these disparities and heightened the need for this as well as other legislation aimed at reducing this blight in our communities. Unfortunately, implicit bias plays a significant role in perpetuating these disparities and these inequities that have plagued the Black and Brown communities for generations, and they must be addressed if we are to achieve true health equity. So how does implicit bias manifest in healthcare today? Multiple studies show that Black patients are less likely to have their pain adequately controlled and more likely to be considered drug seeking, including when they're in a sickle cell crisis or have just had surgery. And it's assumed that Black Americans have a higher pain threshold, which was really left over from experimentation that occurred during slavery without anesthesia. And this was sort of the lie that the physicians told themselves to really perpetuate what we consider to be barbaric behaviors today. But in fact, there are no scientific evidence to support that Blacks have a higher pain threshold than other groups. Another example is that physicians assume that patients from minoritized communities are less intelligent and less likely to adhere to treatment recommendations. This is a residual from eugenics theory, which at the turn of the last century assumed that some groups were biologically inferior to others. Again, science has refuted this today. So because unconscious bias can influence medical decision-making in a way that can be harmful to our patients, at Johns Hopkins Medicine, we're addressing this issue directly by requiring unconscious bias training for all of our managers and leaders, as well as for all of our trainees. And that includes our medical and graduate students, our residents, and our postdocs. This will serve as a foundational element for more in-depth anti-oppression training over the next 2 to 3 years that will not only address racism, but also sexism, heterosexism, ableism, ageism, as well as xenophobia. So Johns Hopkins urges a favorable report on House Bill 28. And I thank you for allowing me the opportunity to speak with you about this issue for which I have great passion, and I'm happy to answer any questions when that time comes. Thank you.
Thank you, Doctor. Next, we have Dr. Khalisha Hussain.
Hello. Thank you very much for this opportunity. And I recognize Chair Pendergrass and members of the Health and Government Operations Committee. I was a former founding director of the Office of Minority Health and Health Disparities, so it is still very close to my heart. This office is uniquely positioned to put health disparities data by race and ethnicity on its website and share it with healthcare providers. This information is essential to reach awareness within healthcare delivery, health education institutions, and health research systems that will move them to focus on reducing health disparities. The state office is uniquely positioned to monitor and report on those disparities that persist and resist costly funds from our state, resulting in poor health and preventable death in the public and private sector. I also support the Office of Minority Health and Health Disparities taking the lead to move both government and the private sector toward aggressive remediation of the implicit bias. Implicit bias has plagued this nation for hundreds of years. Left unattended, it has mutated into re-expansion of explicit bias, which we have recently seen in the nation's capital. And finally, implicit bias in healthcare settings has again resulted in avoidable COVID-19 illnesses and death, which was recently mentioned. And it's been abetted by the social determinants of health, which persists. Leadership in providing unconscious bias training for health professionals could be the single intervention that state government could launch that would lead to a measurable reduction in most of the health disparities we experience in Maryland. And in closing, to achieve both of these very essential interventions, there must be adequate and sustained funding and staff expertise that survive the changes in political and top leadership. And I'm available to answer questions as they may come up. Thank you.
Thank you. So are there any questions? We have Delegate Morgan.
Thank you, Madam Chair. Sorry about a little late on the mute. My question was for Dr. K, but did he drop off the line?
No, I'm here. Delegate.
Hey, oh, okay. There you go, Dr. K. Hey, you mentioned racism as a public health crisis. Can you tell me when you have a statistical disparity between two groups, when is racism not indicated?
I'm not quite sure I exactly understand your question, Delegate.
Well, you're saying that there's let's say a group of African Americans and a group of Caucasians. You're saying there's a disparity between the two, so therefore you're assigning racism as the reason for the disparity. And I'm asking you, when there is a disparity, when is racism not the reason why?
I get it. I get it. Okay. So I think it's not an either or situation, right? It's one of the things that's kind of a hallmark of this is that there are multiple factors that lead to disparities. Typically, if there's only one reason, it's pretty easy to identify and move on from it. But what we see is that these health disparities, particularly racial and ethnic disparities, but we look at a range of them, have persisted for decades. They're not something that we've just seen recently and have gone away and morph. I think Dr. Golden spoke to the fact that they've been going on. We've been describing this in the literature for centuries. And so the question is, what's underlying that and what does that look like? So when we say that racism is a public health issue, that isn't something that we're saying just as a county. This is something that's been stated by the American Public Health Association, by the American College of Physicians. There's a really large body of work that looks at social determinants of health and those underlying factors that lead to persistent disparities between groups. And so that's why when we look at the data in our county, across the state and across the country, that's where that determination comes from.
So any consistent disparity, the result is racism. Is that what?
No, I don't believe I said that. I said that there are persistent disparities along racial and ethnic lines that are sometimes really that aren't really resistant to solutions. I think COVID is actually a really great demonstration of that, of what it means when a new virus that didn't exist prior to December 2019 and it hits our state, and within weeks there's a disparity that occurs in terms of who's getting it, who's dying from it. It's somewhat remarkable, and it's actually tracking along issues that have far predated the arrival of COVID. And I think that's really what we're getting at when we talk about racism as a public health issue, is that it creates this underlying situation, essentially this underlying substrate, that whether you have a new virus or existing diseases, you see these persistent disparities. There are other reasons too. I'm not dismissing those other reasons. This is simply one that is a strong undercurrent.
Thank you, Madam Chair.
My pleasure. Delegate Bagnall, followed by Delegate Hill.
Thank you, Madam Chair and Madam Vice Chair and committee and thank you for bringing this bill. My question is related to the health disparities that we already are aware of and that we're already working on. We know we have disparities in maternal outcomes, maternal mortality, in diabetes, in identified in COVID. Would this bill give us a mechanism to tie those efforts together in a more unified way so that we're not approaching these health disparities in quite as piecemeal of direction as we have been?
I might be happy to take a stab at answering that.
Absolutely.
So I think, I'm a diabetes specialist by training, but interestingly, all of the contributors to disparities in diabetes also contribute to disparities in cancer and disparities in other chronic disease outcomes. So I think one of the things that COVID has really taught us is to look further back at the structures and like what are interventions that we can do at the health system level and also with our health policy and some of our social policies that address the issues that are at the root of all disparities. And so, the idea, for example, with unconscious bias training for clinicians is you're not going to just focus on that training for clinicians who treat patients with diabetes because there's a disparity in diabetes, but this would actually, all clinicians, regardless of the specialty that they're in or the types of patients they take care of, would get that training because those biases then influence all the different decisions that are made. And so I think what we like about this particular bill is that it's actually looking at disparities, intervention to address disparities as a whole, as opposed to one particular disease, because many of the diseases have the same root causes.
Thank you so much.
Thank you, Dr. Golden. Delegate Hill.
Thank you, Madam Chair, and thank
My
you
pleasure.
for this bill, this really important bill. I'm going to direct this one, I guess, to Dr. Kalyana, and it's good to see you again. So I'm going to follow up on Delegate Morgan's question. Can you clarify for us when you're talking about public health issues, when you say water quality is a public health issue or poverty is a public health issue, isn't that similar to what you're saying here, that if you don't identify the root causes, it's really hard to come to solutions? And so you didn't say race is a public health issue. The statement of this bill is that racism is a public health. Am I right about this, or am I missing something?
No, I think that's a fair interpretation of it, Delegate Hill, and good to see you again as well. We see in public health, we see that there are large factors that typically have very small impacts on individual people, but when you add it up across a population, you see an effect. And I think one of the biggest challenges we have is that in public health is that I can't tell you who is going to be adversely affected by it. I can tell you generally how many. And that's what makes this challenging, right? When we talk about racism, it has small but tangible effects on individuals, larger on some, less on others. But overall, over a population, it has effects. And very similarly, when we talk about water quality, that's an excellent example. Air quality, it's another example. Smoking cessation, the oft quoted was, well, not everybody who smokes get cancer, lung cancer, and some people who get lung cancer didn't smoke. While that is true, smoking increased rates of lung cancer in those people who did smoke, right? So that's really what we're talking about, is that it has an effect over a population that is tangible at that level. And so it warrants addressing.
Thank you very much.
Thank you. I don't see any other questions. Let me confirm. Seeing none. Thank you so much, panelists. Next, we have actually the favor support with amendment. We have Ms. Casemeyer.
Hi, Pam Casemeyer. Hi, members of the committee. Nice to see you virtually, or whatever it is we're supposed to be saying right now. And anyway, it won't take a lot of your time, because I think you've heard from a lot of really knowledgeable people, far knowledgeable than me. But we've submitted a written testimony. I'm here on behalf of a broad range of healthcare providers, the Academy of Pediatrics, OBGYNs, emergency docs, federally qualified health centers, clinical social workers. It'll take my 2 minutes to name all the provider community that is supportive of this initiative and believe that the implicit bias training framework that's included in here really makes a lot of sense. It requires it. It phases it in. It makes it requirements that the courses are recognized by their boards. So it's an excellent framework and critically important. If you wonder about the amendment, it's actually something that I believe that the sponsor herself will be offering. The only slight amendment, I would call it technical, is implementation timeframe, requiring the course to be completed by providers for their first renewal after April 1st of next year. It's a technical amendment because right now it would require it within 30 days of the bill's effective date. And it's not likely that all the boards and everyone else can figure out what courses comply and all of those things within 30 days and have the provider take it. So we are extremely supportive of this bill, but ask for a little time to get the framework in place before it applies to licensure renewal. Thank you, Madam Sponsor, for your willingness to talk about that piece of it. It's tiny, but that is what I'll raise because everyone else did a fabulous job with the subject matter.
Vice Chair, you need to unmute yourself.
I'm sorry, I thought I was unmuted. I don't see any questions for this witness. Thank you so much for your testimony today. This concludes the bill hearing on House Bill 28. Next, members, we're going to House Bill 309, Public Health Data, Race and Ethnicity Information. I want to thank you all for giving me the time this afternoon. Thank you, Madam Chairman, for allowing me to present House Bill 309 and members of the committee. House Bill 309 basically does the following. We have learned just in the last 25 minutes that access to data is a critical component of understanding and addressing healthcare disparities, and it has been illustrated and discussed beautifully. So House Bill 309 does the following. It would require the Office of Minority Health and Health Disparities to collaborate with the Maryland Healthcare Commission to publish a health disparity policy report card. And again, the last time that was done was in 2010. It expands the collection of racial and ethnic data from all licensed healthcare providers. Presently, we do it just for physicians. So this basically is expanding it to all. And under this legislation, each health occupation board authorized to issue a license or certificate should include the option for an applicant to provide their race and ethnicity. And they also should, basically what the bill does is tells the boards to encourage the applicant. And you notice that it does not mandate it, okay? It encourages for them to provide it. The office also shall, to the extent possible, under the federal and state privacy law, respond to requests for health data that includes race and ethnicity information within 30 days of receipt of the request. And finally, the office must meet annually with the Maryland Healthcare Commission, which they keep a lot of data and they do a lot of studies to examine the collection of race and ethnicity data in order to identify any changes, in order to improve the life of the Black and brown people, the people that are being affected the most, and they have the most disparities in many subjects in this state. So I respectfully request a favorable report. I know I have a little more than 3 minutes left, and I would like to give my time, in addition to his 2 minutes, to Mr. Craig Bean, who's next. Thank you.
Great, good afternoon. Thank you, Madam Chair, members of the committee for having me. My name is Craig Bem. I am the Maryland Executive Director for CRISP. We are the state designated health information exchange. Our vision is to advance health and wellness by deploying technology through cooperation and collaboration. And first, I'd like to say that I really appreciate Delegate Pena-Melnick's efforts and everyone's efforts to reduce healthcare disparities and improve health equity. It's obviously a vital topic, as everyone has been saying for quite a while now. CRISP is primarily a technology company. And so while I can't speak to the specific policy or what you all would like to do to improve health equity, I can kind of echo what many people have been saying about the data. In our experience, it is critical to have consistent, standard, kind of thoughtful data collection practices and to understand really as much as you can about a population in a way that minimizes the burden on the data collection and that can be done privately and securely. I think a good example is certainly COVID-19. As everyone tries to understand the best interventions for populations of people or to understand where health disparities might happen, it's really hard to do that when there's this unknown denominator of people who maybe have an unknown or NA listed as race and ethnicity. Or if you don't understand language preferences, it's very hard to drive action related to reducing healthcare disparities. And so just very broadly, we think that being deliberate and thoughtful about collecting the information and using the information would certainly help the much broader healthcare efforts that the state is undergoing during the total cost of care model and just much more broadly for public health.
Thank you, Mr. Bam. Next, we have Ms. Karen Kala. Actually, excuse me, Ms. Erin Dorian.
Great. Thank you, Madam Vice Chair, and thank you, members of the committee. My name is Erin Dorian, and I'm the Director of Government Affairs and Policy for the Maryland Hospital Association. As you heard my colleague say earlier when testifying on the previous bill, over the summer, the MHA Executive Committee adopted MHA's commitment to racial equity. While much of this work is internal to the hospital field, we understand that there is a need to adopt public policy to promote racial equity in the healthcare sector and beyond. I'd like to thank the Vice Chair Pena Melnick for introducing HB 309, which seeks to improve collection of health data stratified by race and ethnicity. This is an important foundation for building meaningful public policy to improve health equity and build a diverse workforce. Any of these efforts will require access to robust, accurate, and Maryland-specific data. Past efforts to improve data collection on patient health outcomes, healthcare quality, and patient stratification by race were not coordinated or sustainable. Furthermore, to truly build a healthcare workforce that reflects the Maryland's population, which we believe is the end goal, we will need to know the demographic makeup of the current healthcare workforce. This information is also currently not available. We believe HB 309 helps to build the critical data infrastructure needed to inform future policy efforts aimed at reducing health disparities and increasing health equity. For these reasons, I urge a favorable report on HB 309. Thank you.
Thank you for your testimony today and your support. Next, we have Ms. Pam Casemeyer.
Sorry, it would be helpful if I could find my mute button. Members of the committee, Pam Casemeyer here on behalf of MedChi and the Mid-Atlantic Association of Community Health Centers, as well as a number of other healthcare provider groups. Again, in support of this legislation, I don't know that I have a lot of substance to add to what you've already heard from the few previous witnesses. They've really done a good job summarizing it, but wanted to let you know that we definitely will endorse and understand and believe that data collection and analysis is a critical component of understanding and addressing healthcare disparities. Without adequate data and without, sort of granular and broad evaluation of that data and its implications, it becomes very challenging to create meaningful initiatives and policies and programs to address those disparities. And so for those reasons, we believe that the additional data collection and reporting requirements included in this bill will help provide a excellent platform for beginning to develop some real meaningful programs to address these disparities.
Thank you so much for your testimony. Next, we have Dr. Colin Arman.
Thank you, Chairwoman Pendergrass, Vice Chair Pena Melnick, and committee members for this opportunity to testify. It's good to see you again. Since I had the opportunity to testify on HB 28, I will keep my comments very short. I encourage you to provide a favorable report on House Bill 309. I spoke on why data on race and ethnicity is critical to addressing health disparities. In addition to that, we also know that the race and ethnicity of providers has an impact on health outcomes. And so understanding that makeup of the professionals in our health occupations will allow us to work towards addressing issues around cultural competence and around representation in these health professions. And so for those reasons, I encourage you to provide a favorable report. Thank you.
Thank you so much. Dr. Sharita Golden.
All right, so thank you again for the opportunity to speak today about House Bill 309. And again, Johns Hopkins is pleased to support this legislation. And I just want to thank Vice Chair and Delegate Pena Melnick for her leadership on this and the rest of the committee. So my name is Dr. Sharita Golden, Vice President, Chief Diversity Officer, and Professor at Johns Hopkins Medicine. And what I want to add is that a diverse biomedical workforce is really crucial to meeting the needs of the multicultural communities that we serve in order to truly achieve health equity. So currently, according to data from the American Association of Medical Colleges, only 5% of US physicians are Black, only 5.8% are Latinx, and less than 1% are Indigenous. So this limits our ability to deliver truly culturally competent healthcare to our increasingly diverse patient populations, and is yet another contributor to the health disparities we discussed earlier. This is unfortunately a long-term consequence of the closure of all but 2 medical schools training Black physicians following the 1910 Flexner Report on medical education. At Johns Hopkins Medicine, we recognize the need for collecting accurate demographic data on our healthcare workforce to establish benchmarks and goals. So we're building a dashboard to track our key metrics of our healthcare workforce by race, ethnicity, sex, as well as their intersection. So including things like job category, rank, years at rank, salary, promotion, as well as terminations, departures, and reductions in force. And we're doing this for our staff as well as our faculty. We believe that diversity and inclusion in healthcare is a matter of life and death, because the biased decisions that we make may adversely impact clinical outcomes for our patients. During COVID-19, we were able to engage our diverse workforce to support the needs of our Spanish-speaking patients. So as an example, we launched the Juntos program, which means together, that sought to reduce cultural and language isolation for our Latinx patients and their families by connecting them with bilingual clinicians. Had we not had that diverse workforce, we would have been unable to provide that service. So we are pleased to support House Bill 309 and urge a favorable report of this bill. Thank you.
Thank you, Dr. Golden, for your testimony. Are there any questions of this panel? Seeing none, thank you so much for your testimony this afternoon. And that actually concludes the bill hearing on House Bill 309. Next, we have the last bill of the day, which is House Bill 78, Public Health Maryland Commission on Health Equity, the Shirley Nathan Pulliam Health Equity Act of 2021. So I spoke to Shirley, this Senator Nathan Pulliam, this past weekend, and she wanted to come and testify on the bill. And I told her it wasn't necessary because she was in the hospital. So she sends her love. But she is known for all these bills that I put today, Madam Chairman and members of the committee, are really her work. So, you know, I give her the credit. I also would like to thank Delegate Lewis for her work on this bill. So that's why we title it that way, because she deserves the credit. So House Bill 78 is the one that I'm most, believe it or not, excited about, because it's a bill that brings all the different departments of government in the state of Maryland, and it brings them together to meet, to talk, to share and discuss and come up with a plan how to, you know, reduce all these health disparities. So when you talk about whether it's improving access to care, you know, the Department of Health or the Department of Transportation or economic support, or whether it's stable housing, you know, or social justices, you bring everyone together so that people can share their thoughts, their ideas. It provides a much needed forum for us policymakers and other stakeholders to work together to identify what we have been discussing for the last 40 minutes, the root causes of health disparities, and to share information and to be able to share the data and to interpret the data and to try to make life a lot better. So basically the framework is the following. The purpose of the commission is to employ a health equity framework to examine the health of the residents of the state of Maryland to the extent necessary, basically to look for ways for units in state government to collaborate together on policies that will positively impact the health of the residents in Maryland. And the impact of the following factors, like I discussed, will take, you know, will be taken into consideration. And I discussed some, but also the environment or barriers to career success and promotion. How can we make life better for people in Maryland? And they will set goals for health equity, and they will prepare a plan that will be submitted as well. So I am really excited because I think it's necessary. It is going to be, you know, a commission that will stand, there's not a sunset, because they should meet. And it says in the bill that they should meet at least 4 times a year, but it sort of leaves it open if they want to meet more than that as well. The fiscal note is very doable, like less than $70,000, I believe, a year. And you know what? It is worth it because public health is underfunded. And this is really the right thing to do to bring all these, you know, intelligent people and policymakers together. So I'm going to stop there and give my time to Mr. Beam. Thank you so much for allowing me to present it to you. Mr. Beam, you're next.
Yep. Good afternoon again. Thank you, members of the committee. Craig Bem with CRISP.
I'm so sorry, I mispronounced your name, Bam. Sorry, I should know.
Oh, it's quite all right. I'll answer to anything. No, it's great to see you all again. Again, I certainly can't speak more passionately or as an expert to the policies to reduce healthcare disparities. CRISP is obviously broadly in favor of that. And I will defer to the commission and much wiser people about whether or not this is the best approach, although I think it's a really sound one. What I want to speak to again is the data. And I think one of the really important things, and the thing that we're really excited about, is that this bill takes into account not just understanding kind of broad kind of pictures of zip codes and counties, but it actually looks at individuals to create actionable data. And so maybe a good comparison is thinking about data like a puzzle. When we did COVID-19, understanding different cases or confirmed patients, we looked at positive lab results, which tells you that a person is positive. We then had to link that, just like putting a puzzle together, with prior hospital utilization and with claims information to understand the payers, and with chronic condition data from different healthcare records. And by linking these different things, we could understand what the full individual person was going through, which could then be passed to epidemiologists or healthcare providers to understand the individual, what the individual patient what needed help with. But then the other thing we can do to drive action is de-identify that individual record and create a population report. And so now you're not just understanding that a zip code has a potential disparity, but you're understanding the underlying makeup of the people in the zip code. And you can look for patterns, whether it's along racial or ethnic lines, or maybe upon age, or maybe very small neighborhoods and communities. And by providing that information at the discretion of an advisory committee within the commission, we think the HIE can really drive actionable information. And I don't want to put words in the delegate's mouth, but I'm sure that Delegate Penny-Melnick does not want to see just reports come out. I know she wants to see improvement and actual gains in health equity. And I think having data-driven decisions is the first step to empowering this group to do meaningful things.
Thank you. Next, we have Ms. Erin Dorian.
Thank you, Madam Vice Chair. Again, Erin Dorian from the Maryland Hospital Association. I'd like to thank Vice Chairman Penny-Melnick again for introducing HB 78 and actually all three of the bills she introduced today. We were very happy to be engaged early on in these pieces of legislation and are really here in support of all three. To fully address the systemic issues facing many of Maryland's communities and meaningfully improve the health of all Marylanders, we need to recognize that issues beyond the direct medical care can contribute greatly to an individual's health care outcomes. The creation of the Maryland Commission on Health Equity would ensure that every government agency is engaged in reducing the existing health disparities we see across the state. We also support the legislation's goal to leverage available data through CRISP to empower the commission with the data they need to make informed recommendations. By engaging CRISP early, the commission's advisory committee can shape the health data equity data set using the diverse public and private data available. Lastly, I'd like to take a moment to acknowledge how wonderful it is that this piece of legislation is dedicated to Senator Shirley Nathan Pulliam. Senator Shirley Nathan Pulliam worked tirelessly to improve health equity in Maryland during her long career. And the commission is an important step in fully realizing the health and all policy framework Senator Nathan Pulliam brought to the state when I was a young DLS worker and championed all those years ago. So we urge a favorable report on HB 78.
Thank you. Next, we have Baltimore City Council President Nick J. Mosby.
Delegate Mosby is in another committee right now, so I was wondering if we might come back to him.
Thank you. We have next Mr. Larry Tinsley, the second.
Hello, thank you, Madam Chair and committee members. I'm Larry Tinsley and I'm an RN. My zeal for healthcare reform began to develop early in my career. I encountered patients with chronic disease as I was reminded of my plight with chronic asthma during my childhood. I vividly remembered the emergency room visits becoming extended inpatient admission stays. Growing up in the urban setting of Washington, D.C., Our socioeconomic condition forced my mother to choose between purchasing my asthma medications or buying adequate food for the week on her modest salary of $11,000 per year. I would earn money during the summers to help my mother as much as I could financially. However, our health insurance remained inadequate and the hospital bills continued to accumulate. During my study in nursing school years ago, I had the pleasure of meeting hardworking immigrants who were employed as housekeepers with only limited healthcare insurance. Like my mother years ago, they also made an honest living. However, they too were faced with the dilemma of choosing between buying an antibiotic for their child or feeding a family of 6. Oftentimes, I would provide them with medical counsel on how to treat a family member's ailments. This would save them money otherwise spent on expensive copays and deductibles for doctor visits. It is incumbent upon lawmakers to further examine and mitigate the same disparities that were present during my childhood that still remain some 35 to 40 years later. As with any healthcare encounter, we must adequately assess, diagnose, and treat our population, as well as establish an efficient healthcare system that is of high quality, culturally relevant, comprehensive, and affordable. I applaud the state of Maryland in proposing these efforts in creating legislation that compiles data in an attempt to understand different trends and dynamics that serve to enhance our healthcare system's effectiveness. Thank you.
Thank you for your testimony today. Did Mr. Mosby sign in?
Yes.
He's here.
Okay, wonderful. Good afternoon.
Thank you, Madam Vice Chair. It's a pleasure seeing you as well as fellow colleagues. Wanted to come and just thank you for your leadership on this particular bill. As mentioned earlier, the American Public Health Association, the National Association of County and Health Officials, as well as the American Academy of Pediatrics have declared racism as a public health crisis. And I don't think this bill could be timely enough as it relates to the circumstances, the byproducts, and the residual effects that we expect to see coming out of COVID-19. Last year, as a delegate, I wrote to the governor, I wrote to the Maryland Health Department to release data, disaggregated data based off of race and ethnicity, because there was a huge concern that the COVID-19 was going to affect certain communities, particularly underserved communities, in ways that we have not seen prior. And what I did not want to occur was in 2 years or 3 years, there'd be some study or there'd be some white paper to talk about we didn't deal and address with the issues that were present at this particular moment. When we released that data, we saw exactly what was. We saw that underserved communities were affected much greater. We know that African Americans in our state die at a rate 2 times higher. And we're seeing those same type of implications of the past play out with the vaccination administration. I believe there was a report that says about 15% of African Americans have been the ones that have taken vaccinations in the state of Maryland, which is completely desperate in comparison to the ones that have been affected. We also know that last year's pandemic, there was a 2-fold increase in completed suicides in the African American community as it relates to, again, all the residual, the byproduct effects associated with where we are with this pandemic. So this bill couldn't be more timely. If we had a commission of folks in place that was looking at this on a regular basis, I know that Maryland would be on a better trajectory for our underserved communities. Again, Madam Vice Chair, thank you for bringing this important legislation forward, and I urge the committee to support.
Thank you, and you're missed. Thank you. And it's great to see you on behalf of my colleagues. Welcome. So the last witness of the day, Mr. Larry Polsky, and he's favorable with amendments.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Larry Polsky. I'm representing the Maryland Association of County Health Officers in support of HB 78 with one amendment, which would add a local health department representative to the commission. In Calvert, we have a mini version of the commission proposed by this bill. And as the vaccines for COVID began rolling out, we recognized 2 key pieces of public health data. One, I'm sure you're all aware, and this is picking up on what President Mosby just said, that African Americans have suffered at significantly higher rates during COVID, in both in terms of serious illness and deaths. And second is that historically members of the African American community have been more hesitant to receive vaccines than the general public. And as an example, for flu vaccines, the average African American is 25% less likely to be vaccinated against the flu than members of the general community. So we were very concerned that if this trend continued, that we would continue to see increasing disparities in illness and death, and more to the point that there would be preventable loss of life at that point. So our little commission decided on a plan, and what we did was we prioritized leadership of our local African American, both civic organization leaders and religious congregation leaders. This way, instead of them just talking to their organizations and encouraging, that they could go to them and say that I have already been vaccinated. In addition, we took still photos and we taped 30-second interviews in people's own words as to why those vaccinations were important to them. And at around Martin Luther King Day, those photos and those videos were broadcast out as part of our public relations effort. Well, as President Mosby just said, across Maryland, rates of COVID vaccinations for African Americans are 50% lower than for the general population. But in Calvert, there is zero disparity at this point. So the reason I'm bringing that up is that commissions like this can work. What they need are proper leadership and vision, but they provide a point where we can organize and coalesce, and to Delegate Bagnall's point on a prior bill, also help to organize what oftentimes are disparate efforts into one cohesive whole. So I greatly encourage you to support HB 78, and Madam Vice Chair, thank you very much for your sponsorship.
Thank you always for your support and your leadership. Are there any questions for this panel? Seeing none, thank you so much, members and chairman, for being with us today. This concludes the bill hearings today, and this concludes the bill hearing on House Bill 78. Thank you so much. Have a blessed evening.